Okay. Hi, my name is Srikar Adhikari. I'm one of the faculty in the Emergency Medicine Department at University of Arizona. The topic today is about POCUS stewardship. Let me go ahead and introduce the topic, and then I'm going to turn this over to Hamid. As you all know, POCUS is widely used, not only in emergency medicine, but also in other specialties as well. As ultrasound, the technology is advancing and the equipment is becoming smaller and smaller. Now there are a lot of handheld devices available in the market. So the use of point-of-care ultrasound is rapidly proliferating across the specialties. With that rapid evolution, there comes, are we using it the right way we're supposed to use? Initially, we started out saying that, okay, we'll see if there's pericardial effusion, yes or no. So it was initially about yes or no answers. Now we are using it to assess a variety of symptoms, clinical syndromes and whatnot. So just because we have a hammer, are we hitting every possible nail? So that's the debate we're having at this point. So are we using the point-of-care ultrasound just like any other diagnostic test? Are we using it in the right way? So that's where POCUS stewardship comes into play. It has several components, which includes indications, pretest probability, diagnostic characteristics of the test, and also spectrum of the disease as well. So with that introduction, I'm going to turn this over to Hamid, and he's going to review in detail all of those items I just mentioned. Thank you.
Thank you, Dr. Adhikari. There's the stewardship that I am about to talk in less than 18 minutes. So I want to just really outline what are we using the POCUS at this point. And in the ED, we describe how that the impact of pretest probability and test characteristic on the actual outcome and the result of the POCUS and how we're integrating. And describe the element of something that we call that POCUS stewardship. So what is the current state of the POCUS in clinical practice? What are we using ultrasound for? And what situation we are dealing with? One important character and nature of the work in the ED is complexity of the critical scenario. It's not just only one thing, it's not just P. You have respiratory distress, can be P, can be CHF, can be tamponade, can be anything. You are seeing a lot of people, they are using POCUS that from the most expert and the least expert. And all those criteria that's affecting the result of what we are gaining from that POCUS result. And obviously the diversity of venue of the using ultrasound. Ultrasound has become more wide, streamlined, is just using and more expanding. And question for us right now on the topic is this any harm on this? Benefits, you guys all in here because you know that the benefits and we all advocate for benefit. If I'm talking about harm, it does not mean that I'm just saying bad thing about the ultrasound. I just want to make sure we are having one specific topic that is harmed by doing too much ultrasound on inappropriate ultrasound. Why does that matter for us, not for the radiologist? Radiologist is getting the order from clinician. And the clinician and the result that provided by the sonographer and the radiology is the protocol based. But what we do, we totally differentiated from that. Why? We are using it, we are ordering basically, we are performing it. So if the order is wrong, performance is going to be wrong. So we have a too low threshold and too high threshold a lot of time for actually performing the scan. And based on all these things, we carry along a lot of biases. So if you are doing it unnecessary and inappropriate, the cost of doing unnecessary is a lot of downside effect on the patient safety. So let's do how we can fix it. But this talk is all about integration. It's not about how to get images, how to do this, how to do that. All we want to talk about right now, how to safely and properly integrate POCUS in your maximize the benefit of the actual scan that you do. Every scan we do has 3 components. Some components, some criteria is related to the patient, some related to the machine, and the POCUS practice, and some related to severity of this. And as you can see, we're going to discuss in this one. This sounds like just showing this animal that has nothing to do, but really the stewardship is all about characteristic of these three different animals. If you look at the first one, chameleons is actually, they are having two chameleons is all for pretest probability. Sensitivity and specificity is all about panda effect. And the gorilla effect is the spectrum bias. Let's walk on one by one. Look at this video here. This is a pretest probability making. What we do in the ED is like this. Chameleons, each eye is independently moving all different directions, but as soon as they see the right direction and same target, both eyes come on one focus, and that's you. That's us in the ED, providing when you are starting with ultrasound, if you're starting from the last part and focusing on the target without looking for it, you are missing a lot of stuff in here. So this chameleon effect, it means you pretest probability need to be built right before you start doing POCUS. Therefore, we do not have the term random POCUS. We do not have the POCUS that is not indicated. Because before any of this one we do, we need to have a dynamic pretest refining. Next thing we do is here actually, so this is all because avoiding confirmation bias, avoiding anchoring bias. Remember, I said you are ordering and you are performing. If you already anchored, all ultrasound is helping you try to prove your agenda that's already been based on the wrong information or built in the wrong direction. So how we integrate actually in this one to be better? First, as I said, consider pretest probability. How we consider in pretest probability? We are having the diagram a lot every single day. I'm not going to try to just talk about numbers. Look at here. For any situation that we are getting involved for imaging, we have a testing threshold. We are not CTing or even ultrasounding everybody that's coming in the door. We have test threshold that is based on pretest probability we have. Certain cases, patient is coming, typical PE, with or without ultrasound, you started treatment because the CT is not available or patient has a contrast allergy. That's already reached to the treatment threshold. Doing ultrasound and avoiding doing that treatment, that is not a stewardship. Starting doing ultrasound just because available and is not reaching to the test threshold is not stewardship. Example, the people, they are working in fast track, leg swelling, the patient is coming and they are thinking, well, they don't want to even send dimer, they don't want a DVT, they think this is a lymphedema. Plan to discharge. They are running into Dr. Dikari and they say, oh, you're here, can you take a look at the ultrasound? That is against stewardship. You are not reaching to testing threshold just because it's available ultrasound and practice, you are doing it. So that is come with a false positive and false negative. On the other hand, reaching to threshold, look at this picture. So you have this, as I said, this clinical scenario matters. So healthy 36 years old, the URI symptom is coming, is not reaching to the cardiac ultrasound because you think this patient has a flu or has something related. But if the scenario is changed, the same person, second visit during COVID, coming and has a URI symptom with worsening dyspnea, where is the testing threshold for these two? For the first one is all to the left, and you see the right word moving for the actually second one. This is the first one, low pretest probability, and that's the second one. You see clearly cardiomyopathy or myocarditis as a result of that actually COVID in this patient. So that clinical indication is must, clinical context is key, and clinical integration is next thing to do. Next thing we want to talk about is a little bit more uncertainty. What is uncertainty? Dealing every single day with EAR practice. From everything that is come out the door, from knowing nothing, you are practicing, you are ordering stuff, and knowing everything about the patient, you're still refining that certainty. Uncertainty is the dealing what we are having every single day in the emergency department. to me, the most important indication for ultrasound is dealing with uncertainty and narrowing down that uncertainty. As you can see clearly, you need to improve it from high uncertainty. This is the low uncertainty. And this is your chameleon effect, right sitting in here and watching 360 up and down and find it. Giving you an example. This is the case that is coming with the ultrasound with the actually like respiratory distress. This is the dealing we have in here. And on the top of all these, the criteria that you need to deal with COVID that is sitting over there and not moving. So example, this is the patient hypotensive, hypoxic is coming in the ED, and actually just has a pneumonia, CHF, and maybe actually, this is the picture you see. Is this patient has a tamponade? Quite possible. You continue a scanning, you say tamponade, yes, perfusion, yes. This patient has pneumonia, the patient has PE, and the patient has tamponade. Which one is actually more important? That's not the one that we can sort it out, but this is the one, this is not the question you have. The question we have is this: do I have room for IV fluid for this patient? Do I have room to just give the patient positive pressure ventilation because of this? Do I have room to just say, do I need to start vasopressor for them? Or I need to go for precardicentesis right away? Those are the questions. But what you don't want to do is to look for B-lines instead of calling for BiPAP, because you are a sono person. So this patient that you walk in, the patient is sat in 70%, I cannot breathe. The first thing you call in is the BiPAP rather than the echo, rather than ultrasound. Next one, you don't call, say, okay, let me see if I need to intubate this patient or not. Intubation is not based on ultrasound that you want to say. Or you look at over there and you say, oh, this RV is not dilated. Let's cancel the CT scan. That is not the best use of POCUS. That is not a stewardship. On the other hand, hitting the threshold, actually also another one that we talked about it earlier. So the patient is coming clear-cut, actually CHF exacerbation. You are seeing this picture. And so do you need this even a picture? This patient needs to start treatment without ultrasound. Using it, delaying care. Another example of this actually hitting threshold. Patient with gunshot wound to the abdomen. Fast, we all know how important fast it is. But that patient needs the operating room more than they needed to have an ultrasound to confirm the patient needed. We do not send GSW to the abdomen based on what ultrasound shows. We send that based on the practice we are doing for the trauma for this patient. So I'm going to move on a little bit faster in here because I want to just make sure that we all really just getting summarizing in here. The test threshold, if you are not getting to the test threshold to send that patient for DVT ultrasound, do not do it in the ED. If you are not reaching to the patient has a treatment threshold and ultrasound not supposed to and won't change the directional management, you need to consider not to do it, or at least not to do it just on the first hand. That was about the pretest probability. Let's focus on the sensitivity and the specificity. This is my panda effect. Why I call that panda? It's this video that you guys seen it from the first case that you see, this one. You see the panda is only black and white, big panda. I see it, I am pretty sure. You are sure, I am sure. But if you're adding up to the number of pandas towards the end, some of them you don't even know if a panda is down there. You don't know is the black or white. We all know it's a black and white picture. We want it. But many of these pandas and many of the other colors exist. So we have a range of accuracy based on provider, based on different machine, and based on different exams. All that's creating, and it's just like different sensitivity. But if you are not considering this limitation, that's going to be a problem. For the first case we talked, look at this patient, sensitivity 83%, specificity 83% for that. Where we are looking for that sensitivity and specificity, we are looking for literature. We are looking for the data, see what we have out there on different setting, because we are practicing different setting, different population. If the generalized data is out there that actually how to practice, how to use an integration, that's going to be the answer. This is the patient, 4 days of the abdominal pain. We know this is the appendicitis, sensitivity 86%. We are actually specificity 91%, and everybody agreed this one is. But not ultrasound has the same sensitivity, obviously, or specificity. Several indications, they have different level of impact, and that's the one you can see. Look at the impact of a likelihood ratio for DVT, 30. Likelihood ratio for PE, 4. That's why I'm saying if the patient need to be evaluated for BE, just not seeing the RV does not mean you stop it. Kidney stone, 2.8. Hydronephrosis with the kidney stone, we are not looking for the actual stone, we are looking for the hydronephrosis. A lot of them not obstructive, a lot of them that actually not collecting, a lot of them we are calling wrong, 2.8. For necrotizing fasciitis, you see 13. So appendicitis, 30. That's why we say we need to make sure that this is actually being part of the practice. The other thing I want you to see here, the impact of the pretest probability on sensitivity. And this is actually, you can see that when you have a DVT in here, pretest probability low is 0.5 and the 17 and 40. Post-test, when you are looking at the N1, look at 95%, 86%, and 20%. So this is very important to know then. When you have a low pretest probability, your sensitivity is lower. When you have high pretest probability, your sensitivity is better. And that is bring me to the last part of this talk, that is a spectrum effect. What am I talking about, the spectrum effect? This is different from a spectrum bias. This is a spectrum effect. It's a real effect of the severity of the presentation. So this is not about who is doing ultrasound. It is not about what patient it is. This is about how severe the situation, the condition, and the disease is. If you are towards the end of the most severe part of any scan, your accuracy is better. That's the gorilla. When you have a large, fast examination, you are not going to miss it. Every single student can get that one, and they are right. There is not a lot of false positive, false negative when you are having higher severity of the case. When it's on the other hand, when it's the lower severity, those are the part that is actually we all getting, you call it positive, I call it negative, the other one is call it this one. This ultrasound call it positive, the other ultrasound machine is make it better picture, all get false positive and negative. So why I'm just important, it's important for me to focus on this gorilla effect. Gorilla effect to our practice and integration is huge. Let's look at this picture. I am pretty sure every one of you guys can say the picture to the right is positive fast. But maybe if I vote, it's just probably maybe just a few of you guys say positive, negative for the first one. Okay, so why is that? Because this is the gorilla effect. This is not going to be missed, okay? So let's just focus on an M&M case. This is a 44 years old. I changed all the age and gender and stuff and to make sure it's not traceable. This is the M&M case. 44 years old, status post MVC, GCS of 7, intubated in the field. FAST is showing this one. FAST is showing this one. I'm pretty sure some of you guys, maybe positive. Some of you guys say maybe negative. So it's been called positive. And based on this, it's been sent to the operating room, and they have nothing in the abdomen, and the patient arrested actually during on the table and died. So we call this one, look at here, and this is all the exam you have. Based on this, it's been called positive, okay? So the question is, what is wrong they do it? They've been very sensitive. No, they were sensitive because this patient, instead of going to the CT and make sure there's nothing in the brain, they've been sent to the operating room because they call that positive. And this patient is hypotensive. Question is, if each patient is hypotensive because of this, that must be actually severely dilated, actually a lot of fluid in the abdomen, not just that one. This one is the patient of 4 days of the appendicitis picture. Some positive, some negative. Do you call this? This is the gorilla effect. If the patient is 4 days signs of appendicitis, after 4 days must be positive. And this is the picture of 4 days appendicitis that is hard to miss. As you can see it across this room actually. So I'm finalizing just less than 1 minute. So this is the, as you can see, appendicitis towards the end, severe, the duration is increasing the severity, and towards the end, sensitivity is greater than 90%. So if you have the symptoms start this morning, you're going to call that wrong a lot of time. If it's actually 4 days out, if you don't see appendicitis, look for an alternative. The bottom line is the stewardship is really the right way to improve and create that integration properly. Start with integration, looking for pretest probability, looking for a spectrum effect and sensitivity and specificity of the test, and from the top, decrease and narrow down your uncertainty towards the likelihood ratio that matters. So therefore, the POCUS should not be used if it's not clinically indicated. So we already have a lot of example. Results should be actually just based on the likelihood ratio that can change the things. And that we need to know that there is a limitation, harms, and cost associated with unnecessary scanning. Thank you very much, and I'm happy to answer any question you might have.
Thank you, Dr. Shokouhi. I'm looking at the list to see on the chat to see if there are any questions. I don't see any, and we are unfortunately out of time, but we're going to allow maybe a minute or so for questions. Any questions at all?
I don't have a question, but thank you so much for this talk. I mean, it's such an important topic that I feel like is not talked about enough. And you've given me a lot of ammunition for my residents and learners to kind of hammer this home. So thank you.
Thank you all.
Thank you very much. Have a good afternoon. Thanks for the presentation.